This lecture covers spinal cord injuries. Spinal cord injuries are injuries that are caused by trauma or damage that is done to the spinal cord. It results in either temporary or permanent alteration in the function of the spinal cord. About 12,000 Americans each year suffer from spinal cord injuries. 81% of people with spinal cord injuries are males. The highest incidence runs between the ages of 16 and 30 years old. About 90% of all patients with an SCI are discharged from the hospital to home or to another non-institutional type of residence. Only 10% are discharged to nursing home, chronic care facilities, or group homes. Motor vehicle accidents account for half of all spinal cord injuries in the United States. Of the remaining half of SCIs that occur here in the US, about 16% of those are due to falls, 12% due to violence, particularly gunshot wounds, and another 10% to sports injuries. The other 14% are other miscellaneous types of injuries that lead to the spinal cord injury. And in about 25% of all spinal cord injuries, alcohol has played a role. Spinal cord injuries occur as a result of a number of different reasons. They may be the result of compression, contusion, or ischemia of the spinal cord that was a result of a vertebral fracture, or possibly hyperflexion or hyperextension of the spinal column. They may be the result of tearing or transection of the spinal cord due to a penetrating trauma, such as a gunshot wound or a stab wound. The extent of the neurologic damage caused by a spinal cord injury results from both primary injury damage, which is the actual physical disruption of the axons, and secondary injury damage, which is the ischemia, hypoxia, hemorrhage, and possibly edema that follows the primary injury. Primary spinal cord injuries are the result of the damage to the vertebrae, the ligaments, or the discs of the spinal column, or the damage done to the spinal cord itself. A traumatic spinal cord injury could stem from a sudden traumatic blow to the spine that fractures, dislocates, crushes, or compresses one or more vertebrae. It could also be the result of a gunshot or a knife wound that has penetrated and cut the spinal cord. Secondary injury is the additional damage that occurs over minutes, days, or even weeks as a result of bleeding, swelling, inflammation, and fluid accumulation in and around the spinal cord. Normally, the blood-brain barrier prevents substances such as white blood cells from entering the spinal cord, but with spinal cord injuries, the blood-brain barrier is broken, which triggers the inflammatory response. The edema during the secondary damage can extend to the spinal cord segments both above and below the actual injury, thus increasing the ischemia to the spinal cord and potentially increasing the overall area of damage. Because the secondary injury progresses over time, the extent of the injury and the prognosis for recovery are usually most accurately determined about 72 hours or more after the original injury. About 50% of people with acute spinal cord injuries experience a temporary neurologic syndrome known as spinal shock. Immediately after the spinal cord injury, there can be a physiological loss of all spinal cord function below the level of the injury. This can include flaccid paralysis, absent bowel and bladder control, and a loss of reflex activity. This type of shock is characterized by a decrease in the reflexes, a loss of sensation, and flaccid paralysis below the level of the injury. In addition, the patient will experience urinary and bowel retention during this stage. This altered physiological state can last anywhere from several hours to several weeks, on average, a minimum of 24 hours up to 6 weeks and sometimes more. This syndrome can mask post-injury neurological function, and sometimes it takes some time to determine the patient's actual full extent of their injuries because we have to wait until spinal shock has resolved. Resolution of spinal shock is marked by spastic involuntary movements of the extremities below the level of the injury. Another potential complication with the spinal cord injured patient is neurogenic shock. Spinal shock and neurogenic shock can oftentimes be confused. However, neurogenic shock describes the hemodynamic changes that result from the sudden loss of the autonomic tone due to the spinal cord injury. Neurogenic shock is most commonly seen when the level of the injury is above T6. Spinal shock, on the other hand, refers to the loss of all sensation below the level of the injury, and it's not circulatory in nature. And it is possible for both neurogenic shock and spinal shock to coexist in a patient. As I just mentioned, neurogenic shock, in contrast to spinal shock, is due to the loss of vasomotor tone that's caused by the injury. Neurogenic shock is characterized by hypotension and bradycardia in the patient. The loss of the sympathetic nervous system innervation causes peripheral vasodilation, it causes venous pooling, and ultimately a decreased cardiac output in the patient. And as I mentioned already as well, these effects are usually more often associated with a patient who has a high cervical or high thoracic injury. Again, that T6 or higher. Patients going into neurogenic shock are going to require aggressive fluid resuscitation and vasopressors to maintain an adequate blood pressure and an adequate cardiac output. Neurogenic shock is found in about half of the individuals who suffer T6 or higher spinal cord injuries within the first 24 hours. And it usually does not go away completely for about 1 to 3 weeks following their injury. Spinal cord injuries are classified by 3 different sets of criteria: the mechanism of the injury, the level of the injury, and the degree of the injury. First, the mechanism of the injury is possibly the flexion, the hyperextension, the rotation, or the compression that occurred to the spinal cord. Basically, the mechanism of the injury is the manner in which the physical injury actually occurred. Was it a fall from a high level, from a ground level? Was it a high or low speed motor vehicle accident? It could have been from ejection from a vehicle or a vehicle rollover, just to name a few examples. The mechanism of injury is used to estimate the forces involved in the trauma and then the potential severity for other wounds, fractures, or internal organ damage that the patient may suffer as a result of the injury. Flexion injuries of the cervical spine can rupture the posterior ligaments. Hyperextension injuries of the cervical spine can rupture the anterior ligaments. Compression fractures of the vertebrae can force bony fragments into the spinal canal. And flexion rotation injuries of the cervical spine can often result in tearing of the ligaments that normally stabilize the spine. So again, that mechanism of injury is really just looking at what was the exact physical injury that actually occurred with the patient's spinal column. Next, we look at the level of injury, and we look at skeletal versus neurological with the level of injury. The higher the level of the skeletal injury, the more encompassing the neurological injury is going to be. The skeletal level of injury is the vertebral level where there is the most damage done to the vertebral bones and ligaments. The neurological level of injury is the lowest segment of the spinal cord that remains normal sensory and motor function on both sides of the body. So the level of injury can be cervical, thoracic, lumbar, or sacral. Cervical and lumbar injuries are the most common because these are the levels that are associated with the greatest flexibility and movement within the spinal column. Injuries between C1 and C4 may result in instant death because the nerves that control respiration are interrupted. If this type of injury is survived, the patient will require round-the-clock care and likely will not be able to breathe independently. With high cervical spine injuries such as this, the loss of motor and sensory function is present generally in all 4 extremities. This is known as tetraplegia. It used to be referred to as quadriplegia. The lower the damage in the cervical cord area, the less likely the arms are to actually be completely paralyzed. So they're more likely to have some residual function in the upper extremities with the lower cervical injuries, C5 through C7. Cervical injuries at C5 or below generally spare the diaphragm, which means that the patient may be able to breathe on their own. However, it can involve impairment of the intercostal and the abdominal muscles, which can affect their ability to properly ventilate or move air in and out. Also, patients with C5 or below may have the ability to do some things independently, but that will vary from one individual to the next, and it will be based on their individual injury and recovery and rehabilitation. Paraplegia, in which there is just paralysis of the lower part of the body or the lower extremities, result in injuries usually at T2 or below. If there is any injury to the thoracic, lumbar, or sacral spinal cord, this is when we would be more likely to see paraplegia. The last classification of a spinal cord injury is the degree of the injury. The degree of spinal cord involvement can be either complete or incomplete. The degree of sensory and motor loss varies depending on the level of the injury and the specific nerve tracts that are damaged. If there is complete cord involvement, then that will result in a total loss of sensory and motor function below the level of the injury. But with the incomplete injury, this means that there's still some ability for the spinal cord to convey messages to and from the brain. So with incomplete cord involvement, what you see is a mixed loss of voluntary motor activity and sensation. And then you see some motor activity and sensation remain intact. Because specific tracts are involved with an incomplete injury, we see particular patterns of neurological dysfunction. There are 6 different syndromes associated with the incomplete injuries, and we're going to look at them over the next several slides. But they are known as central cord syndrome, anterior cord syndrome, Brown-Séquard syndrome, posterior cord syndrome, and then our final slide looks at quadra equina syndrome and conus medullaris syndrome. The first type of incomplete injury that we're going to look at is the central cord syndrome. This is the most common form of cervical spinal cord injury that generally results from hyperextension. It is usually due to some type of trauma to the cervical cord region from a neck injury that leads to major injury in the central gray matter of the spinal cord. It's characterized by disproportionately greater motor impairment in the upper compared with the lower extremities. We also see bladder dysfunction and a variable degree of sensory loss below the level of the injury. So ultimately, with central cord syndrome, there is a loss of motion and sensation in the arms and hands. Motor weakness and sensory loss are present in both the upper and lower extremities, but the upper extremities are affected more than the lower extremities. Also, central cord syndrome is more common in older adults. As we go through each one of these different types of incomplete injuries, it's going to be important for you to distinguish the identifying characteristics of each type of syndrome. So you'll want to pay attention to the particular manifestations that are described with each one. The next type of incomplete spinal cord injury that we look at is the Brown-Séquard syndrome. Brown-Séquard syndrome results from damage to 1/2 of the spinal cord. So this type of injury typically results from a penetrating trauma to the spinal cord. It could be a blunt trauma, a disc, or a bone herniation. It could possibly be a hematoma or even maybe a tumor. The patient will experience different deficits on each side of their body with the Brown-Séquard syndrome. So as you see in your notes, on the same side as the injury occurred, what we call the ipsilateral side, the patient will experience a loss of motor function and position and their vibratory sense. On their contralateral side, which is their side opposite where their injury occurred, they will have a loss of pain and temperature sensation below the level of the injury. And now also make note, Whatever they have lost on one side, they retain on the other. So as I just mentioned, that on their contralateral side, they have a loss of pain and temperature sensation below the level of the injury. That also means that on their ipsilateral side, they actually retain the sensation of pain and the sensation of temperature. Next, we look at anterior cord syndrome. This typically results from acute compression due to a fractured vertebrae or an acute disc herniation. This is an injury that causes damage to the anterior spinal artery, and it results in compromised blood flow to the anterior part of the spinal cord. With this particular injury, the patient experiences motor paralysis and a loss of both pain and temperature sensation below their level of the injury. However, because the posterior cord tracts remain intact and they're not injured, the patient's sensation of touch, position, vibration, and motion actually remain intact. Next, we look at posterior cord syndrome. This is a very rare condition, so it is the most uncommon type of incomplete injury that we see. This results from compression or damage done to the posterior spinal artery. With this particular injury, the patient loses their sense of proprioception, vibration, and fine touch below the level of the injury, but they retain their sensation of pain, temperature, and motor function below the level of injury. The most common symptoms associated with posterior cord syndrome are problems with gait ataxia and paresthesia. Quada equina and conus medullaris are two final types of incomplete injuries that we can see in our spinal cord injured patients. We've talked about quada equina before in the musculoskeletal lecture in relation to patients with herniated discs. And so what I did was make a chart here for you to compare these two types of incomplete injuries and see what are the differences between the two. So first, just to explain, the conus medullaris is the bundled, tapered end of the spinal cord nerves. It's situated just near the first two lumbar vertebrae, and it leads into the quada equina. So the conus medullaris ends as the quada equina begins. The quada equina then is a bundle of nerve roots at the very end of the spinal cord, and they're distal to the conus medullaris. Sometimes conus medullaris syndrome and quada equina syndrome can have some similar symptoms that can cause it to be difficult to distinguish between the two. So despite some of their similarities, the two spinal cord injuries often do manifest themselves in different ways, which is why I created the chart for you to do the comparison. First of all, take a look at the causes. With conus medullaris, we generally see the cause due to some type of severe trauma to the lower back. Versus the quada equina syndrome, which we've talked about previously, the most common cause for it is a herniated disc. As far as the vertebral level goes, the conus medullaris is just a little higher in the L1 to L2 area versus the quada equina ranging from the L2 to the sacrum. Skipping to the row on how it presents itself, another notable difference here is that conus medullaris, because of the type of injury it's generally associated with, will occur suddenly and affect both sides of the body, versus quada equina syndrome has a tendency to come on more gradually and only affect one side of the body. The pain level with conus medullaris tends to be more mild to moderate, and yet it's severe with quada equina. Another important notable difference between the two is the areas of numbness for each one. With the conus medullaris, the numbness tends to be more localized specifically to the area around the anus. With quada equina syndrome, we describe it as being located more in the what we call the saddle area, which is around the buttocks, but also the inner thighs. Pretty much any area that would touch a saddle if you were sitting on one. With both types, there is no single treatment. It does depend on the test results. It often is going to include possibly some surgery, radiation, even some physical therapy. It's really going to depend on the specific type of injury, what has led to the injury itself, and what kind of problems or symptoms the patient is experiencing. We talked about quad equina syndrome previously being considered more of a medical emergency, especially if the patient reports any sudden changes in their bowel and bladder habits. Usually that is a justifiable reason to warrant surgery being done rather quickly. During the first few days after an acute spinal cord injury, every doctor, nurse, healthcare professional that comes in contact with that patient bears a major responsibility. This is because the final outcome of a spinal cord injury greatly depends upon the accuracy, the adequacy, and the speed of any first aid treatment, the diagnosis of the patient, and the treatment, all that is done within the first few hours of that injury. Management in the acute phase is going to be aimed at preventing any further spinal cord injury, as well as maintaining physiological stability, and then commencing with routine care of the skin and establishing good bowel and bladder care as well. So we begin by talking about the effects of the spinal cord injury and the care of the spinal cord patient by talking about that initial care in that acute phase. Certainly, we're going to be focusing on our ABCs during this phase. It's going to be critical, obviously, that we maintain a patent airway. And in order to do that in the spinal cord injured patient, or the patient at this point with just a suspected spinal cord injury, one of the most important interventions that you can do is to stabilize the cervical spine. Stabilizing the cervical spine does, in effect, help to maintain your patent airway. If you don't stabilize the cervical spine prior to beginning any other interventions with the patient, you risk doing further damage and compromising that patient's airway. If necessary, we would administer oxygen via nasal cannula or non-rebreather. Also, in this initial acute phase or this emergent care phase, we want to make sure that we establish multiple IV access sites so that we can infuse fluids as needed, again, with that anticipation of, again, the suspected spinal cord injured patient would also be at risk for the potential for the neurogenic shock to develop. We want to control any external bleeding if there is any present, assess for any other injuries for the patient. Again, just reiterating, one of our major goals at this point in the beginning of care is protection of the patient from any extension of or further injury of that spinal cord trauma. We will also be obtaining imaging to verify the extent and types of injury of the patient and preparing them for stabilization with either tongs or traction. Both the Gardner-Wills tongs and the halo traction are used for spinal traction to maintain cervical stabilization with certain cervical fractures. With the Gardner-Wills tongs, there are some limitations to that particular device. It's best used short term because the patient does have to remain bed bound. They are attached to traction that is bearing weight. Patients can have up to 70 pounds of weight applied to the Gardner-Wills tongs traction in order to maintain cervical alignment. With the halo traction, that is better for long-term use. It can be worn for up to 6 to 12 weeks, and the patient can be mobile with that type of traction in place. In regards to the respiratory status of the spinal cord injured patient, the first 48 hours following that injury, we can see spinal cord edema possibly increase the level of dysfunction, and respiratory distress can develop. So even if we don't see any indication of respiratory distress immediately upon receiving the patient, we want to watch very carefully over that first 48-hour period for the potential for respiratory distress to develop as a result of secondary injury. Also remembering that those cervical injuries above C4 present special problems for the patient because there is a total loss of respiratory muscle function. Those injuries that come in at C4 or higher, mechanical ventilation is going to be necessary to keep that patient alive. Injuries or fractures below C4 can cause some problems with breathing. Even if it's below that, it's going to be that secondary damage such as edema that's going to put that patient at risk for respiratory insufficiency. Hypoventilation is also a common problem, even with the injuries below C4 as a result of impairment of the intercostal muscles. Additionally, even with both the cervical and the thoracic level injuries, we can see paralysis of abdominal muscles possibly, and paralysis or weakness of the intercostal muscles as well. With these problems, the patient usually cannot cough effectively enough to remove secretions. This can lead to problems like atelectasis and pneumonia. And so some patients, if they do have some weakness of their abdominal and intercostal muscles, they may need what is known as the quad cough. The quad cough is a caregiver-assisted cough that is aimed to mimic the action of the abdominal muscles and pushing the diaphragm upwards and inwards. The quad cough, or the assisted cough as it's known, can be done either lying down or sitting up. The caregiver places the heels of their hands or their closed fists midway between the umbilicus and the sternum on the patient's abdomen. As the patient is about to cough, the caregiver presses firmly inwards and upwards toward the diaphragm to assist in producing an effective cough. In regards to the cardiovascular system, we want to recall that those injuries above T6 are going to be at high risk for the development of neurogenic shock, which is going to potentially cause bradycardia and hypotension. Also recalling that patients in neurogenic shock will also experience a decrease in cardiac output because the peripheral vasodilation reduces the capacity of the dilated veins. So in regards to treatment with the cardiac system, patients with spinal cord injuries are going to require cardiac monitoring. They possibly may require the administration of the appropriate medications such as atropine if they experience episodes of marked bradycardia. And they're possibly going to need those IV fluids or vasopressor drugs to support their blood pressure. We also want to be very cautious with any type of vagal stimulation, such as suctioning, because that can result in cardiac arrest of the patient. Urinary retention is also a common development in acute spinal cord injuries and in association with spinal shock. While the patient is in spinal shock, the bladder is atonic and it becomes overdistended. An indwelling catheter is going to be necessary during the initial acute phase of the spinal cord injured patient in order to drain the bladder. In the post-acute period, the bladder control is variable. Some patients continue to need an indwelling catheter. Some are able to learn to self-catheterize and do the intermittent catheterization, and some patients are actually able to regain reflex control of their bladder. Overfilling of the bladder can still occur for the remainder of their lifetime related to abnormalities with their loss of sensation and their fullness. And over time, if this happens repeatedly, it can lead to an increased risk for renal failure in the patient. Another aspect is in the early period when spinal shock is present, the bowel is what we call areflexic, and the sphincter tone is decreased. So the patient's not going to have a bowel movement during spinal shock. But as the reflexes return, the bowel becomes reflexic, and the sphincter tone is enhanced, and what we call reflex emptying then occurs with the bowel. In both areflexic and reflexic neurogenic bowel, they can be managed successfully as long as a regular bowel program is developed, and this does help to minimize fecal incontinence with the patient. A couple of notes is if this spinal cord injury has occurred above the level of T5, the patient is more likely to have gastrointestinal problems related to hypomotility. Their decreased GI motor activity can contribute to the increased risk for the development of paralytic ileus and gastric distension. They're more likely to need a nasogastric tube for intermittent suctioning in order to relieve gastric distension. Medications like metoclopramide or Reglan can be used to treat their delayed gastric emptying. Another risk factor for these individuals is the potential for the development of a stress ulcer because they do have a tendency to have excessive release of hydrochloric acid in the stomach. Another focus in the care of the spinal cord injured patient is thermoregulation. Patients with spinal cord injuries are unable to control their body temperature below the level of the injury. And so it's very important that the ambient temperature or the room temperature is controlled closely and that the patient is properly clothed and prepared for the temperature or the environment in which they're in. There's a term called poikilothermism, and this can occur in the spinal cord injured patient. Poikilothermism is when the body temperature adjusts to the room temperature. This occurs in spinal cord injured patients because there's an interruption of the sympathetic nervous system and it prevents the peripheral temperature sensation from ever reaching the hypothalamus. Now, the degree of poikilothermism in a spinal cord injured patient depends on the level of the injury, of course. Patients with high cervical injuries have a greater loss in the ability to regulate their temperature than those with thoracic or lumbar level injuries. Another note with thermoregulation is that patients with spinal cord disruption also have a decreased ability to sweat or shiver below the level of their injury, which is going to be another factor that will affect their ability, again, to regulate that body temperature. Skin integrity is, again, one more aspect here that we need to look at with this spinal cord injured patient. A major consequence of the lack of movement certainly is going to be the potential for skin breakdown, especially over those bony prominences and in areas of decreased or absent sensation. Pressure ulcers can occur very quickly in spinal cord injured patients below the level of their injury, and they can be a cause of major infections and sepsis in the long term for these patients. So we want to be very aggressive with turning, repositioning of the patient with a spinal cord injury, checking for any areas of abnormal pressure, and making sure that we initiate proper interventions quickly. One additional concern we have for the spinal cord injured patient is the potential for autonomic dysreflexia. Autonomic dysreflexia is a massive, uncompensated cardiovascular reaction that is generated by the sympathetic nervous system. It involves stimulation of sensory receptors below the level of injury, and ultimately it causes vasoconstriction and a dramatically increased blood pressure. This is a condition that occurs most often after the first year following the injury. However, we can see it begin as soon as spinal shock subsides. But because we are more likely to see it once more than a year has passed since their injury occurred, it's really important for us to teach the patient about the signs and symptoms of autonomic dysreflexia and the patient's caregivers. Not only do we need to teach them to watch for the signs and symptoms, but we also need to teach them what the necessary interventions are going to be for the patient when autonomic dysreflexia develops. First, one of the most common causes that we see this happen, it's going to be due to either a distended bladder or rectum, but it can be caused by some sort of abnormal sensory stimulation as well. This could be stimulation of the skin or even stimulation of the pain receptors. Manifestations of autonomic dysreflexia include one of the primary symptoms is hypertension with a systolic blood pressure upwards of 300 millimeters of mercury. The patient would report a throbbing headache. You would also be able to note marked diaphoresis above the level of the injury, along with piloerection, which is erection of the body hair and flushing of the skin. Below the level of the injury, the patient will be cold and pale. Some other symptoms they might report would be nasal congestion, possibly blurred vision, nausea, anxiety. And we may also see bradycardia develop, which could be as low as 30 to 40 beats per minute. It's important to always make sure to measure the blood pressure in a patient with a spinal cord injury anytime they complain of a headache, because the headache is probably one of the most prominent symptoms that they may actually report, whereas the hypertension is going to be one of the most prominent symptoms that we may actually assess. They're not going to be able to report their blood pressure to us until we obviously take it. The condition is a life-threatening situation that does require immediate resolution. If the resolution does not occur, the condition can lead to status epilepticus, a stroke, possibly an MI, and even death. So when autonomic dysreflexia is recognized, the initiation of certain interventions are going to be immediately necessary. One of the first things you want to do is elevate the patient's head of the bed to 45 degrees or sit the patient completely upright. Once this is done, we need to determine the cause. So in determining the cause, we need to make sure that we first want to check the bowel and bladder to see if there is anything causing distension there. If the patient has a catheter in place, you would want to check it to see if there are any kinks or occlusions in the catheter. If the catheter is kinked and we just need to unfold it, that might fix the problem. However, if it does seem to have some sort of occlusion or sediment in the catheter, it's possible that it would need to be irrigated. We can try a low volume, slow irrigation to try to open a plugged catheter, or we can just immediately insert a new catheter. If the patient doesn't have a catheter in place, that's one approach that you may want to try, is the immediate catheterization to try to relieve the bladder distension. If bladder distension is ruled out and you suspect that it's possibly rectal distension from maybe a stool impaction, because this can also trigger autonomic dysreflexia, then a digital rectal examination should be performed, but it should only be done with the use of an anesthetic ointment, because you do want to make sure that you, and so like an anesthetic ointment would be like a lidocaine jelly to decrease the rectal stimulation and prevent an increase in symptoms such as that vagal stimulation, which would cause a worsening of the bradycardia. Some other interventions that you can do while you're determining the cause of the autonomic dysreflexia is to remove any type of skin stimuli, such as constrictive clothing or tight shoes. Additionally, you do want to make sure that you monitor the blood pressure frequently throughout the episode, and continue to monitor the vital signs until they stabilize. Most patients with spinal cord injuries will have PRN orders for blood pressure management in the event that autonomic dysreflexia does develop. And certainly, as the nurse caring for this patient, you would also want to make sure that you notify the physician that autonomic dysreflexia has developed in the patient. Also, you want to make sure that you teach both the patient and the caregiver to recognize the causes and the symptoms of autonomic dysreflexia. They also need to understand the interventions necessary to treat it, and the fact that this is a life-threatening event. If they observe it occurring, they need to know how to relieve all of the causes of autonomic dysreflexia as well. After a spinal cord injury rehabilitation will be necessary in order to optimize the recovery and perhaps help the patient adapt to a new way of life. The treatment and the rehabilitation process of spinal cord injuries is very long, expensive, and it does require a multidisciplinary approach. Early rehabilitation is important and critical to prevent disability and complications in the spinal cord injured patient. Spinal cord injury rehabilitation centers are oftentimes a stop between the acute care and the patient's home. Spinal cord injury rehabilitation centers not only involve learning techniques for adjusting to their activities of daily living, but also they often provide back to work counseling to help the individual realize whether they can return to their previous job or if they need to seek a new career. They also oftentimes provide, for those who aren't working but maybe still in school, they can provide back to school preparedness to help both the individual and the institution assimilate to this new injury. Rehab also not only involves the patient, but it involves the family as well, within that multidisciplinary approach.